Thank you very much, Chairman. And thank you to our witnesses today for being here. I want to raise a bill I co-authored, if I may, H.R. 4299, the Protecting Patient Access to Cancer and Complex Therapies Act. This bill addresses the negotiation provisions in the IRA, the Inflation Reduction Act, that relate to drugs often administered or infused in independent community settings. This setting of care is one that we have to work to protect, as it provides critical points of access for patients across the country, delivering high quality of care in a cost-effective manner. Under the IRA provisions, the negotiation is synonymous to a direct reimbursement cut to providers who are already facing significant financial pressures. Recent analysis by Avalara Projects shows that on average, independent providers are going to face a 47% cut in their reimbursements. And this is, specifically a lot of Part B medicines. That makes stocking and administering these life-saving therapies a net loss, and forcing difficult financial decisions on physicians in that situation. This bill provides a very simple technical fix, replacing the direct provider reimbursement cut with a back-end rebate by the manufacturers to CMS. And this will allow the system and the patients to still see the benefit of price reductions while removing the physician from the equation. Without that fix, though, the lack of reimbursement is sure to become another critical factor, forcing consolidation, again, of care and more expensive and less patient-centric care. Dr. Azis, can you provide some perspective on what additional reimbursement cuts might mean for patients?
Well, the physicians in America are in a crisis in terms of reimbursement and payment. As you've heard, costs are rising dramatically, whether it's the cost of insurance, the cost of rent, the cost of employees, the cost of everything we do to maintain our practices as a business and keep them open. And that crisis is what's accelerating further consolidation and independent practices to go out of business. So anything that will help prevent that from occurring is beneficial to the survival of independent practices.
That was my experience in practice as well. Mr. Pollack, hospitals play a central role in providing care for complex and emergency cases. How are hospitals responding to this growing number of physician practices that are being acquired and consolidated for financial purposes?
Yes, one of the things that's important to look at when you see this issue is that hospitals really are not the major drivers in acquiring physician practices. Over the last 4 years, the increase in in physician practices has been, acquisitions has been by private equity.
Yeah, I've noticed that.
And second to that has been medical groups. Third to that is insurers, and we're the last, 6% increase. Now, what's important to remember is that we recognize that physician employment is not the only model. And there are a lot of different ways to affiliate with our physician partners. But sometimes we are approached by physicians who want to be a part of a hospital system.
I get that. It's obviously they're just having trouble keeping their doors open, and so they're
and the overhead costs associated with maintaining electronic medical records, cybersecurity, dealing with the insurers, and they want to be associated with us.
the compliance costs alone are staggering. Let me be in my limited time. I want to turn back to Dr. Azis and say we were let's see. Physicians are frequently, they cite administrative burdens, prior authorization, as drivers of burnout and increased cost. From the AMA's perspective, how much time and money are physicians spending on administrative tasks instead of patient care?
So physicians are spending a huge amount of time dealing with administrative tasks. In my own practice, I have 2 people full-time just dealing with prior authorization. So I always tell my patients now that when I write a prescription, I consider it a recommendation because I don't know what's going to be filled, because we have to go through a prior authorization process frequently to get basic, long-standing generic drugs approved so that I can treat my patient's glaucoma or whatever the problem may be.
It's absolutely frustrating. And, you know, I want to close with saying, I think that requiring prior authorization, whether on the part of an insurance company or whatever, is the practice of medicine. And I would invite them into the medical liability arena. You and I have to pay med-mal insurance, so should they. With that, Mr. Chairman, I yield back.